Hello, everyone, and welcome to our panel discussion on the role of advocacy in addressing health inequities. Over the last 2 decades, we've seen a lot of focus on health inequities within communities, within countries, but also across the world. The COVID pandemic in the last 18 months has both exposed and exacerbated inequities in public health, both within communities and across countries. And so for local public health advocates, it's very critical that as they are working on various policies, they are mindful of addressing health inequities. Today, I'm joined by a very distinguished panel of international experts from India, from Ecuador, and from Brazil, who are working on different healthcare policies to hear from them how they are taking into account health inequities, taking into account different voices, different issues in addressing the health policies they are working on. So without further delay, I'm going to introduce my first panelist, Vanessa Manfre Garcia de Souza, who is technical advisor for FIAN Brazil. Vanessa worked at the Collaborating Center on School Food and Nutrition and at the National Coordination of the Program at the Ministry of Education. Currently, she is technical advisor on PNAE and the coordinator of the project Growing and Learning with Real Food for the Right to Adequate Food and Nutrition at School. So Vanessa, over to you.
Olá a todas as pessoas aqui presentes.
Hello to everybody listening to us and here present. On behalf of FIAN Brazil, I want to thank you heartily for my invitation to participate here. I'm going to bring the example of the program in Brazil with meals to all students in public schools in our country, and the objective is contribute to the learning of food practices that are healthy for students. We know that schools should promote health at all times. We need rules to govern the food provided in schools. In Brazil, we do have guidelines for purchasing and for the supply of food for this national program. We can highlight some of them. The employment of food programs that respect the culture, the food habits, and everything else. This is very important also to sustain and to maintain the sustainable, the food preferably being produced locally, especially family farms, and always with the focus on the indigenous communities and the Quilombola community. Purchasing food from these local producers increases the availability of fresh food and decreases the availability of ultra-processed foods, contributing to school food, preventing obesity, and promoting and fostering student health. The science shows the high consumption of ultra-processed foods increases the risk of obesity and other chronic diseases. According to the Ministry of Health, in Brazil today, we can say there are 7 million teenagers and kids with obesity. Last year, 7% approximately of less than 5 years old kids presented obesity. We need to improve the quality of the food offered in public schools, and we need to foster healthy eating habits and the health overall of our kids and teenagers. The program in Brazil, aligned to the food guide, establishes limits of purchase and supply chain for these ultra-processed foods. Some studies indicate, studies made with the students, they show that food in school is already showing less consumption of ultra-processed foods. There is popularity in healthy food choices for schools and decreasing obesity. However, we do have the obesity problem and we have the increasing hunger right now in Brazil. These are indicators, of course, of social and economic inequality and racial disparities in health in Brazil. The supply of healthy food in school, it's a fundamental and crucial tool to battle these two big issues, the obesity and the hunger, and the most vulnerable groups in society and the inequality. Looking at these two things, the National Food Program, it shows that in the case of indigenous and quilombola students, we need more attention to them. The menus need to meet the cultural specificities of indigenous and quilombola communities. And these communities have priority in the sale of food for the program. These measures favor the availability and the access by groups that are the most vulnerable in Brazil and the access to locally produced foods, decreasing the supply of ultra-processed foods. The program supplies food appropriate to each group of students, biological difference, social differences, cultural differences too, promoting therefore the food sovereignty for these communities, more healthy choices for students, the sustainability of these politics and the policies, and also the producers of these foods. We have a scenario right now of even greater inequality. The traditional communities, the indigenous, the Black Brazilian population have been suffering the worst effects of the COVID-19 epidemic. These are the groups that have the least access to good foods and to health. So this program is even more relevant as a policy at this time in Brazil. Finally, the programs to supply food like these national program in Brazil should foster equity. This is a human principle for healthy foods, and FIAN, FIAN in Brazil is an organization that works to foster this, exactly this human right. We follow and track violations of the rights to adequate food, and one of our lines of work, we have actions to foster the adherence to the national programs, and we have lines of action to increase the supply of food by the small family farms and by local producers. This is what I wanted to bring to get the debate started here, and my heartfelt thank you to the organizers, and I'm ready for the rest of our panel.
We're going to move to our next speaker from a different continent working on a very different issue, but with an eye to addressing health disparities. Radhika Khajuria is Senior Policy Consultant for the Campaign for Tobacco-Free Kids. And she is a gender, health, and labor rights advocate who has worked for the last 2 decades on issues of equity, human rights, and justice with UN bodies as well as local NGOs. Currently, she's leading a coalition of Bidi Workers and civil society advocates to address inequities in their health condition as well as move forward with tobacco policy goals. Radhika, over to you.
Thanks, Vandana. So today, in the time allotted to me, I'm going to talk about one of the most vulnerable sections of India, which is the Bidi Workers, and how our policy, our work in India on tobacco control, the entire process, as well as the goal that we had to kind of give a better life to Bidi workers and win their support for tobacco control, really kind of looked at the health inequities and brought their inequities in this context of COVID up to the forefront. Next, please. So before I start, I just wanted to give an overview to the global audience out here on what is the problem of bidis in India. Now, bidis is like the most smoked tobacco product. 72% of all smokers in India are bidi smokers. And what is bidi? Bidi is a traditional cigarette. It's a tobacco wrapped in this tendu leaf, which is found in the forests of India. It's usually smoked by men, but produced mainly by hand at home by women and young children. And this operates in this vast Indian country in about 17 states, and where about 5 million workers are there in this work, and 90% of them are these women belonging to the most exploited, marginalized communities. They are mostly Muslims. They are the backward, OBC, and the lower castes of India. Next, please. So BDs, why this issue of having a policy goal to kind of support tobacco control in India is regarded as a poor man's pleasure, because it's smoked largely by the poor men living in rural areas. It's deliberately kept extremely cheap, and the labor is exploited of these women. And because of these artificially depressed costs, and the low taxes, BD kind of wreaks havoc among both the users of BD as well as the one who produce, which are the women and children. So they have been reeling under enormous economic and health burden. Now, this multi-generational work that these women and children do, the women do it and they pass it on to their children. This leads to a lot of diseases for them. And it's an unorganized nature because it is primarily made at home, and which leads to a huge amount of problems in regulating the working conditions and implementing labor welfare laws. Next, please. So this feminization of the BD industry, where we have about 5 million women and children, and that's a conservative estimate, they face a lot of exploitation, negative health effects. So most of these women, they report verbal, physical abuse based on their gender, caste differences. We have testimonies of sexual harassment, violence. We're seeing young children here in deplorable conditions, making this handhold tobacco product to be consumed for men across India. Next, please. So given the problem, how did we approach it? We followed 3 phases of our work. The first phase in tobacco control, how to work with Bidi workers, especially in the context of a very oppressive and a very powerful tobacco industry, which was hand in glove with policymakers. We kind of felt that the first thing is to bring the voices of Bidi workers, address the health equity issues. So the aim was to select an organization, map the violations of rights and entitlements. We focused on 3 states. Simultaneously, we found groups, that were led by these BD workers in 4 states. And then we also had supporting research to understand how this industry works and what are the violations systematically that take place at different levels, in this BD work. And this led to a national advocacy plan where all stakeholders were brought together at one platform to spell out what would be the way, to move on addressing tobacco control, the BD, the very contentious BD issues, but the BD workers being kept center stage. Next, please. And therefore, this, we had this intensive engagement led to national consultations, needs assessment of BD workers from across the country. Next, please. In the second phase, these solidarities of support were deepened in each of these 4 states of India with regard to these groups giving issue-based support to tobacco control. Initially, we had 80 BD worker champion leaders who were identified after a systematic process, who were open to speaking out against the exploitation meted to them by the tobacco industry. And these women really took it on as their own to kind of, it was an organic process, and they realized, how how the violations take place at multiple levels, and chose to speak out for a better future for themselves. Next, please. These trainings address various issues: the lack of confidence, the lack of information, help them, connect causality, the inability to formulate demands. So in these states, we had, through residential and offline workshops, we had these women who had developed the muscle to put their, argument very powerfully, not just in front of the industry, but also in front of the government. Next, please. So through this empowerment process and a bottom-up advocacy process, these champions we see are are really like in the leadership process of doing advocacy on tobacco control. Next, please. And Bidi Workers, we saw supported, our campaign on tobacco control, whether it was a tax campaign, they were ready to speak on to the media, or on the national policy amendment, on how they were being used as front groups. Next, please. And the final, process that we followed, there is media that, they were ready to give their voice and give their bites. Next, please. This is a discussion with Bidi workers that were taken to the place of work, which is their home. Next, please. The final third phase is how these Bidi workers are with this bottom-up advocacy. Finally, we saw that we had a national coalition where Bidi work was embedded in this national coalition for women and child rights organizations supporting tobacco control. These Bidi workers were part of intensive discussions, policy level discussions with parliamentarians, including 2 ministers, on the health of women and children, Bidi workers, their welfare issues. And these Bidi workers really articulated their demand on, the health inequity. Next, please. Here we see Bidi workers doing advocacy with the parliamentarians. And this is our Bidi champion, who's very powerfully putting the voice on, the need for alternative livelihood, how the Bidi kind of really has enormous health issues and they need to get out of Bidi into alternative livelihoods, which are safer, healthier, and which will give them dignified work. Next, please. So finally, what we can conclude is that the Bidi advocacy in addressing inequity, where we saw that the process and the final outcome, that how health and labor inequity is woven into the advocacy that we are doing on tobacco control in India. We have seen that the wages, the government has issued an advisory that the wages need to be increased of these Bidi workers because it's abysmally low. And right now in the scenario of COVID, they are doubly exploited. Whatever they are earning, is not enough to face the huge health problems that they have had. Many of them have suffered tremendously as a result of COVID. So whatever they earn is not enough to kind of make their survival. And that's why they have been caught in this, huge circular indebtedness. So this extreme health deprivation and vulnerability is woven into the Bidi policy ask, and we see the Bidi worker champions. Here there are meetings that they are doing with policy makers in their homes and in consultations. Next, please. So I will end with the final thing that declaring Bidi a hazardous industry is a need. So, which is a policy ask that Bidi workers have been supporting. And they need to prioritize healthier and economically viable alternative livelihood. And Bidi taxation has emerged as a very important tool to fund this better welfare programs and livelihood for Bidi workers. This is the kind of policy ask in which the health inequities of Bidi workers have been put in the forefront. I'll end here. Thank you so much.
Thank you so much, Radhika. So with our next panelist, we actually travel back to South America. Paola Carvajal is director of Fundación Ciudadana and is one of Ecuador's foremost experts in road safety, having led the National Transit Agency and was its executive director and later as Minister of Transportation and Public Works from 2014 to 2015. She is currently the director of civil society organization working on road safety issues at the municipal level. So welcome and over to you, Paola.
Muchísimas gracias, Vandana.
Thank you very much, Vandana. It is truly a pleasure to be able to share this panel with you and to be able to talk about the actions we conduct from civil society in favor of health, in my specific case, in favor of road safety. I have a very short presentation to share with you. Thank you very much. Thank you so much. Definitely, road safety is a key equity issue because we must remember that many of the victims are not necessarily the drivers. We have included pedestrians, passengers, and even children who walk to school or infants who were not placed in special car seats or child restraint systems. In fact, supported by the UN and the WHO, the second 10 years of road safety was launched, generating this alert, this warning that crashes are the cause of about 1.3 million fatalities around the world and more than 50 million people being injured. So this gives rise to a commitment around the world to reach a reduction of at least 50% of these deaths on the roads. These traffic crashes are the leading cause of death for young people between 15 and 29 years of age, which means that our youngest people are dying on the roads. In the case of Ecuador, the situation is no different. Road traffic crashes are the sixth cause of death. In 2020, we had close to 17,000 road traffic crashes, more than 13,000 injuries, and almost 1,600 deaths. In 2021, we have not been able to reduce these figures. Up to June 2021, we had already recorded close to 1,000 people dead on the scene. Among these numbers, we have included a vulnerable group, which are motorcyclists. This group calls for special attention based on our reality, given that motorcycles account for 27% of the automotive fleet of close to 2.3 million vehicles. As I said, 27% are motorcycles. This is a percentage which is on the rise significantly every year. Why do we speak about motorcyclists? As I said before, it is a very high percentage of the automotive fleet. Sadly, they do not use all of the right safety systems. In this case, for instance, helmets. This has to do with economic conditions. A helmet, we know, can save the life of a motorcyclist. It's the main safety element. But helmets in our country up to now continue to be significantly costly. If we compare the minimum wage in Ecuador, which is $400, compared to the cost of a certified helmet, which could cost $100 or $120, the decision of low-income families is not to use these types of elements. The cost of helmets is extremely high because of the high levels of tariffs, duties and customs duties related to imports because they are not produced in our country. This is why our organization, Fundación Ciudadana de Movilidad y Seguridad Vial, together with other civil society organizations like Fundación Carvajal or Fundación de Consumidores Ecuador, have conducted research processes. We have mapped information to be able to extend proposals to the National Assembly in relation to the reform to the transit bill and road safety. Together with these organizations and supported by international and national experts, we made some proposals where we included, and because of the work we conducted, they were accepted by lawmakers. In fact, this was sanctioned and included in the reform to the law. This new reform, which was sanctioned on 10 August, was officialized some months back, establishes several actions in favor of road safety, such as speed reduction. In fact, it makes it mandatory for speeds in school zones have a limit of 20 kilometers per hour, understanding that speed can actually be a vaccine to eliminate or to reduce fatalities and injured individuals on our streets. It also gives rise to promotion to control on the roads. But in addition, and this is one of the accomplishments we can share as a civil society organization, it establishes the reduction to 0% of tariff rates for those safety elements or those safety devices, including helmets and child restraint systems equivalent to 0. In other words, the new tariff rate for safety devices will be equivalent to 0%, which ensures that the acquisition cost for these elements will be much less. The cost will be much more available to citizens. But also, something that we accomplished as well, and this is where we believe we introduced innovation, and we are hopeful that this will enable a change and will have a real impact on the reduction of fatalities, is that all stores that sell motorcycles are compelled to deliver, together with the motorcycle, a certified helmet as part of the safety equipment. As vehicles need to have a seat belt or airbags, well, then motorcycles, it has been acknowledged that certified helmets are the minimal safety element that has to be included. This is truly of the utmost importance, because understanding that motorcycles are the transportation means or the vehicle chosen by people of lowest income, they buy them through funding offered by commercial agencies. When the helmet was offered, given that it was so expensive, they left it on the side. Today, since it will be mandatory as part of the equipment provided, they will no longer have to decide to do it or not. It will already be incorporated into the vehicle. This will also allow all of the road control processes not resort to the excuse that I did not buy it, it was not available, or I couldn't find it, because we know that any new motorcycle sold will include a certified helmet. This change, which could seem minor, but which will actually have an impact on reducing fatalities and car crashes, will come into force shortly. In fact, the deadline to reduce tariff rates expires on 10 November. And as civil society organizations and interested in changing these figures, will be vigilant on top of this, because this is our commitment, to be able to save lives and to make coexistence much fairer. Thank you very much.
Thank you so much, Paola. So now we're going to move into the question and answer phase. So I think each of you touched upon this issue, but I want to more explicitly draw out the issue is, what was the status of health inequities related to your particular issue that you're working in your country or community, and how has COVID actually worsened that health inequity? So I'm going to start with Vanessa to address that question, as how has COVID made the health inequity that already existed related to your issue even worse? Vanessa?
No Brasil, a gente já...
In Brazil, we had been suffering already, experiencing a step back in public policies. Before COVID, hunger was already increasing also. The pandemic aggravated the situation that we were already experiencing before. Like I said before, we have these groups that were most heavily impacted in relation to these issues. The indigenous communications, the traditional communities, the Black African descendant population, and the inner cities. At FIAN, FIAN, we have politics and work and programs to defend these populations. We submitted some requests about the food program we work in. We submitted to the Federal Superior Tribunal in Brazil for the necessary measures as far as the federal government to fight hunger in Brazil. We have been practicing very focused strategies for this situation right now, and also regarding the Brazilian students in schools that need so much attention.
Over to you, Radhika, to address that question.
Thanks, Vandana. This question is really important in this context. Already, Bidi workers in India, they were leading a horrible life because they could barely keep their make ends meet. And then we need to understand the very strong connection between tobacco and COVID. Tobacco use exacerbates the, very harmful impact of COVID. People are more susceptible to getting COVID because of tobacco use, prolonged exposure to tobacco. Also, given the health infrastructure in India really collapsed during the second phase of, the COVID, as you all must have known, these people who are at the bottom of the pyramid did not have access to healthcare. Majority of the healthcare is privatized. So again, because they already were suffering with health issues because of, doing Bidi work, tobacco work, and with COVID, things became worse. So the work stopped due to the harsh lockdown. So they were not getting regular work. Plus the health issues became worse. And thirdly, the financial implications of this, they were pushed into a vicious cycle of indebtedness, much more severe and much more, debilitating than before. So really it's, worsened the health inequities of Bidi workers in this COVID scenario.
Thank you so much, Radhika. Over to you, Paola, to answer that same question.
El episodio, bueno, en Ecuador y
Well, in Ecuador, in particular, in my city, Guayaquil, the time of COVID was very difficult. We were compelled, as many other countries around the world, to have almost an absolute limitation of mobility. And with this limitation, not being able to use your vehicles or to use public transportation because there was overcrowding, because of the limitation of mobility, the automotive fleet of motorcycles increased exponentially. And these technological platforms that use motorcycles to deliver either food or any type of product increased. Together with the lack of vehicles or congestion on the streets and the lack of safety elements, the percentage of fatalities and people injured on motorcycles is very significant because we had speed together with the non-use of certified helmets. So actually COVID-19 gave rise to an additional increase which we were not prepared to take on or to deal with. This is why it is so important to ensure the use of all of the safety elements and when we use different means of transportation.
Thank you so much, Paola. So one of the challenges that we face with health disparities, both pre and post COVID, is that we're a lot of times addressing health disparities in communities without actually involving the community itself that is suffering from health disparities. So I'd love to ask all of you sort of, how have you in your work, both pre and post COVID, actually involved the marginalized community that you are trying to address in both, developing the solution as well as advocating for the solution. So maybe I'm going to start with Radhika on that question.
Yes, Vandana, there is a distinct difference between the pre-COVID scenario and during COVID and post-COVID scenario, because now earlier we were doing workshops, Bidi workers were aware, they were trying to understand the causality of why their health is so much impacted due to working with, on tobacco. I mean, multiple cancers, cardiovascular issues, gynec problems, issues with their, shoulders, back, they're sitting at long hours, making tobacco. So that connection that this is occupational health, disease, they are getting the diseases because of the work that they are doing, was difficult before. It was not impossible, but those once they got it, they really realized that this is the reason. It's not something that they're born with. These health disparities have come in, which has worsened their condition because of their work. But COVID actually was a boon in some sense, because unfortunately it was so stark that the causality between the very strong interrelation between COVID and tobacco exposure was so stark that they didn't need to be persuaded. They didn't need to come in workshops. They didn't need to kind of brainstorm and kind of realize that why this occupation is kind of taking a toll on their health. So actually, due to COVID, we didn't have to say anything. They themselves said, we want to get out. We want a better life for our children. We want to get out. And that's when they took the ownership. They were very open that you call us even to the US, we'll come. You call us to the capital, we'll come and we'll speak to all the policymakers that we want to get out of this. And we need to get out of our homes, because at homes, we don't have access to anything. So the violations are very humongous if they stay at home and they work. So actually, COVID catapulted this issue center stage, and the Bidi workers, now took more, they were more excited and more eager to come up and speak to policymakers to bring about a change in their life.
Thank you so much, Radhika. So now we'll move to Vanessa to address the same question.
Bom, a FIAN Brasil...
Yes, FIAN in Brazil, FIAN Brazil, had been following some cases of violations of the proper food rights. The Kaiowá in Mato Grosso do Sul, that is an indigenous community, and Geraseiros, these are traditional communities in the state of Minas Gerais. And before the pandemic and now during the pandemic, like I said, the situation of hunger and food unsafety. We know these populations have not only less access to proper nutrition and food, they also have less access to the health policies and healthcare services in Brazil. We have all these limitations, and we have actions in our organization to develop programs and actions for proper food and health services access. As far as students in the schools, the National School Food Program, we did a survey at the beginning of the year. We realized that food distribution during the pandemic with schools closed, it did not take place in a universal manner. The distribution of healthy food for all the students, not all got them. So we are working on this to insist with the local agencies that manage this program, so that this food can arrive to every student, especially indigenous communities, quilombola communities, and people, families that live in more remote areas. Another line of action, the small producers, the small farms need to continue to be able to supply these healthy products even during the pandemic. There were small contracts with these small family farms. They were suspended during the pandemic. They were no longer selling their food to schools. The students suffers lack of more healthy options, and the small producers were not supplying anymore, and they suffered too. Our actions during the pandemic have been geared exactly to that problem, to strengthen the supply of healthy foods for students, helping to promote food safety for them, students, and for all these communities producing food. Minha última pergunta para todas vocês.
Inequities, completely worsened by COVID, where we have national leaders like yesterday, there was a major speech from the president of Indonesia about how the inequities in vaccine access are significantly worsening the situation in low resource countries, and sometimes even high resource countries. So I would love to hear closing remarks from each one of you as related to your issue. What would be your advice to both policymakers in your country and the globe? So maybe back to you. I'll start with Paola.
Sí, gracias. Yo creo que
Yes, thank you. A recommendation for public policy makers is, specifically in my country, from my experience, given that I worked for the government, it is fundamental to give more space to civil society organizations. These NGOs and civil society organizations produce data and are not at times pressured by the operational nature of public institutions where you have 1,000 things to tend to immediately. So supporting these research processes generated by civil organizations, which are very close to citizens, are instrumental to, in addition, be able to raise awareness. Because something that happens is that at times citizens do not perceive or do not accept in a positive manner the instructions produced by the government, simply even because of a process that because the government is telling you they in principle don't want to accept it. But when you hear it from your peers, from other citizens, and there is an advocacy effort by civil society, very likely it is easier to take it in by the citizens. I think this is a tool that has to be used in a stronger way.
Thank you so much. Over to you, Radhika.
Thanks, Vandana. With regard to policymakers, my two key messages would be whether it's policymakers across the globe or especially in India, please give tobacco control the importance it deserves. There is a strong linkage in this current scenario with COVID and tobacco control. We have like 13 lakh people dying of tobacco related diseases in India. So it's like the huge number of, economic cost, health costs, the countries like India, middle income countries is facing. So please give tobacco control, implement, amend the law. We need to make sure that the law is robust and takes into account the vulnerabilities of the most vulnerable groups and the most marginalized groups. The second message would be that keep the people who are at the bottom of the pyramid, especially in this case, the Bidi workers, the women sitting at home, keep them center stage when making policies, because it is very easy for policymakers to say, well, they are sitting at home, they don't like to come out of the homes, so let's give them this work. So what if they're making a hazardous, making this tobacco, rolling bidis, at least they're not dying of hunger. But everyone has a right to dignified life. Everyone has a life to have healthy alternative livelihoods and not be forced to make, a product that is killing not just the consumers who use it, but it is also killing the women slowly, and the children who are devoid of the future. They are out of schools and they're sitting at home and supporting their families to roll these bidis. So we would want policymakers to kind of, look at the bottom of the pyramid, Bidi workers, their health inequities, and give tobacco control, the importance that it deserves. Clearly, because health, really matters, more so in this, time where we have seen huge loss of deaths because of, COVID. Thank you so much.
Thank you, Radhika. So over to you, Vanessa.
Sim, bom, eu acho que, pelo menos pensando no Brasil, né, é necessário...
Thinking of Brazil, at least, yes, the people responsible for the laws, yes, the policy makers, they need to think harder. They need to pay attention to the increase of obesity in Brazil. We need public policies that fight the availability of ultra-processed foods in all these different scenarios. Schools especially, promoting health and preventing obesity is so important in children and teenagers in Brazil, and it's so important. The government in all levels, local, state, federal, actions to strengthen dialogue space with the population, social participation, strengthening the social control of our public policies, including school food. Listen to the population, open spaces to organizations of the civil society. These are the organizations that take the demands and the needs of these most vulnerable populations. Quero agradecer ao nosso tão distinto painel de especialistas do mundo inteiro, e eu gostaria de enfatizar de novo
this on sort of growing health disparities. The original understanding of health disparities was really around race and ethnicity, but now we realize there's a lot of exacerbating factors, your age, your gender, your socioeconomic status, your religion, and even your geography, as we're finding right now, in a global context. So I think all of us public health advocates, as we heard from Vanessa, Paola, and Radhika, even as we work on very specific policies that we are addressing, it's become even more critical in this post-pandemic world to really be mindful about health inequities, about the last mile, and how do we sort of really make sure that the policy and the interventions and the health systems that we're working on really address the health inequities of that last mile, of that most vulnerable population that is already suffering. So thank you once again to the organizers of the Triangle Global Health Council for giving us this opportunity, and a big thank you to the panel. Thank you so much.
Thank you, Vandana, for moderating it so well. And thank you to everyone, my co-panelists and, the organizers. It was a wonderful experience. Thank you.